Okay, please ready now. Okay, sige. So what was our discussion last meeting? It was about insulin class, especially our insulin preparations. Okay, Munir is present. Sige. And then we have already discussed the different insulin preparations that we have. Please know them with their names and then their classification, whether they are rapid acting or short acting, intermediate acting, and lastly, we have the long acting insulins. Now we will discuss insulin treatment of special circumstance. But before that, let us try to look at this video first. Ready, please. Okay, let's talk about insulin treatment of special circumstance. The first one is diabetes ketoacidosis. This is most common in patients with type 1 diabetes. Though hindi siya masyadong common sa type 2 pero possible pa rin siya. Now this one is a life-threatening emergency, medical emergency that is caused by insufficient amount or even absence of insulin in the body, tapos wala pa talagang replacement, walang insulin from the outside source. So ang tendency, there will be too much increase in the blood sugar level of the person, leading to a lot of complications, including the production of ketone bodies. Kasi remember, di ba, if you have too much sugar in your blood, that means you cannot use it. You cannot have glycolysis because the sugar, the glucose cannot enter the cell. So what will the body do? It will get energy from the other source, especially the fats. Now, if these fats break down, syempre there will be a release of fatty acids and at the same time ketone bodies. Okay, further metabolism of these fatty acids will give us ketone bodies, which is acidic in nature. So that is the reason why the patient may experience ketoacidosis. The blood pH level will be lower than normal. Remember, our blood pH normal range is 7.35 to 7.45. So bababa masyado yung pH, again leading to ketoacidosis. And please remember that if the blood's pH is beyond normal, our cells, our tissues and organs, and even other biomolecules in our body cannot function efficiently. So magsa-stop yan sila ng function if we don't have normal blood pH. That is the reason why diabetes ketoacidosis is life-threatening. So how do we know that a person is experiencing ketoacidosis? So yung sa video, pinakita doon yung mga signs and symptoms just like this one. Siyempre, there is nausea and vomiting, abdominal pain, and itong Cosmos breathing class, ito yung talagang deep na paghinga and at the same time slow. Okay? And then, syempre, the brain will also be affected. Remember, our brain also maintains this normal range of pH. And then, may na siya, may status na yan may changes na sa mental status after. So itong elevated blood glucose level, this is given because definitely there is lack of insulin in this case. And then aside from that, since there is elevated blood glucose level, it will also be passed on via the urine, aside from the ketone bodies produced by the breakdown of the fatty acids in an attempt to get another source of energy from our fats. And syempre, the pH class will be acidic. Okay? Acidic yan siya. And then ito yung second na complication of diabetes mellitus, but this is more seen in type 2 diabetes. Though there is overlap kasi some of the type 1 diabetic patients may also experience hyperosmolar hyperglycemic syndrome. Now, what happened here? If the blood pH, the blood sugar level is not controlled, masyadong mataas yung blood sugar ng patient, the patient may experience dehydration. So nakita kanina sa video yung illustration that remember when you say glucose, it acts as a solute and it is an osmotically active substance. So when you say osmotically active substance, if you have too much glucose in your blood, diba, just like sodium, susunod si water. So there will be osmosis. So water from the cells will get out and go to our blood, making our cells shrink. Kasi nga, wala na siyang water. And if you have too much water in your blood, it means that you will frequently urinate also. So that is the reason why the patient may experience dehydration. Okay? And you know very well that dehydration class, severe dehydration, may be life-threatening. Okay? Life-threatening ito, just like the diabetic ketoacidosis. Life-threatening din si hyperosmolar hyperglycemic syndrome. The patient may experience also coma for this condition. Pwedeng makomatose yung patient natin due to the increase in the blood sugar level as well as the dehydration. Okay? So, elderly patients are at risk of this one. And at the same time, there are also other drugs that can cause this syndrome. So ito yung mga examples of drugs and other things that can cause this. But anyway, this can be seen to patients with type 2 diabetes mellitus if their blood sugar level is not controlled. Okay, so these two again are life-threatening emergencies, and we really need to take good care of our patient if they experience this one. We may give them insulin para ma-counter yung pagtaas ng blood sugar level, and we may also give other symptomatic treatment. Okay, so like when they experience dehydration, we will be giving them fluid replacement. Okay, do you have questions before we'll move on to complications of insulin therapy? Complications naman ito ng insulin therapy, which means that ito din naman yung mga untowards reaction or even side effect of like administering insulin sa body. Wala? Sure? You may ask questions if hindi niyo naintindihan yung pinagsasabi ko dito. Now, sige, walang question. Let's move on. Complications of insulin therapy. Siyempre, if masyadong, example, na sobrahan yung patient ng insulin, there will be overdose, ganon. The patient class may experience hypoglycemia. Okay? So that is the reason why we really need to compute the insulin unit that we are going to administer to the patient, and it should be equivalent to their body weight and their need. Kasi again, there will be hypoglycemia. And how do we know if a patient experiences hypoglycemia? We have sympathetic and parasympathetic effects. For the sympathetic effects, the patient may experience tachycardia. Yeah, it is true that ketone can be seen sa urine of a diabetic patient. Yes. So remember, di ba sabi ko kanina, if we cannot utilize our blood glucose level as source of energy, our body will look for another source, and that will be the fats. And if fats break down, it will give us fatty acids and at the same time ketone bodies. So that is the reason why the patient may experience ketoacidosis, because of that ketone bodies formed, and excess of that ketone bodies will also be seen in the urine. So that is true that ketone bodies are seen in the urine of diabetic patients. Okay, now going back to hypoglycemia, a patient experiencing hypoglycemia may have or may experience also tachycardia and palpitations and sweating, and at the same time tremulousness. There will be shaking class. Okay, pwede siyang magpurog. Okay, ano man to, diba ta? kung ginagutom na ta, wala jud ta ni kaon, gutom na kay talo na kayo ato ang sugar, we may also experience tachycardia and palpitation, and at the same time sweating, and then mangurog na ta sa kagutom. So this is just normally seen for a patient with hypoglycemia. Pero I'm not saying that hypoglycemia is normal. These are just normally seen na mga signs and symptoms. And at the same time, parasympathetic na effect of hypoglycemia is we have nausea and hunger. So mo na siya nga pag gigutom na ka, nga wala jud ka ni kaon, ito yung mafe-feel natin, 'di ba? So in that case, nag-hypoglycemia na tayo. Now, if hayaan kasi yung hypoglycemia, the body will be really depleted with the physiological sugar that will lead to convulsion kasi the nerves there, class, will be firing abnormally already, and you may experience convulsion or even seizure, and the worst thing to happen is makomatose ka if nag-hypogly ka na talaga. Okay? So sometimes patients with diabetes and then administered with insulin, kapag na-feel na nila itong mga signs and symptoms na ito, minsan nag-sugar, hindi naman overload, pero like they consume sugar just to increase their blood glucose level kasi nag-hypoglyce sila after giving the insulin. And then others may also experience hypersensitivity to insulin. So just like with the other drugs, 'di ba, may mga tao talagang parang allergic to a certain drug. Just like I know someone na allergic sa paracetamol and then allergic din sa ibuprofen, and they will really have allergic reactions na visibly seen in their skin. Now, ganun din yung sa insulin therapy. Meron din tayong insulin allergy. So the patient may also experience local or systemic urticaria. That's yung katul-katul no na makita sa lawas. Okay? Because the body will react and will release a lot of histamine after the insulin administration. So this one is the same with the other allergies that we have, that is mediated by IgE antibodies. Okay? And also, some of our diabetic patients in insulin therapy may develop resistance. Okay? Even though we give them insulin from the outside source, after some time, their body will develop resistance and they will not be sensitive to insulin anymore. And by that time, you may have to increase the dose of the patient. Okay? Neutralize kasi yung action of the insulin. Pero most of the time, hindi naman talaga siya parang big deal, or most of the time it's negligible. Pero may mga cases lang talaga na magiging resistance, and you just have to increase the dose of the patient. And ito yung pinaka common na complications in insulin therapy, the lipodystrophy at the injection sites. So remember that insulin, except for regular insulin that can be given intravenously, most of our insulin are given subcutaneously. So we inject that in the between the fats and the skins, most likely in the fats. And if you're going to dispense insulin, class, you really have to advise your patient to change the site of administration from time to time. Kung nag-inject siya sa left side ng kanyang tiyan this day or this week, next week iba na naman na site. Kasi again, the patient may experience lipodystrophy. That means the fat tissues may die, and makikita yan siya parang mangingitim. Okay? Mangingitim yung part na yun kapag you only have one site of injection. So dapat ilipat-lipat natin yung ating pag-inject. Okay? So that's it for our insulin therapy. Do you have questions or clarifications before we'll move on to our discussion about oral anti-diabetic agents, or we call this OHA, oral hypoglycemic agents? This one is more common in the community pharmacy, or even in the Philippines. Most of the time, if it's diabetes mellitus, it will be type 2 kasi yan yung common dito sa atin. And thus, we are going to use most of the time OHA, oral hypoglycemic agents. So again, before tayo mag-move on, questions muna about insulin. Okay. Sige, kindly remind me later. Kasi nakalimutan ko atang i-upload yon. Wala. Wait lang, class. Wait lang for a minute. I'll just answer this one. Ang araw nga na yun. 24, no? 26. Okay, Wednesday. Sige. So, wala, Jud. So, I assume nagkasinabot tayo with our insulin. So, let us move on to our oral anti-diabetic agents. We have several categories for our anti-diabetic agents, class. So, it's really not unusual kung nag-work kayo ngayon sa community pharmacy and you will encounter a lot of them. So how do we classify or categorize our oral hypoglycemic agents? We have the so-called insulin secretagogues. Actually, from the name itself, you will know anong trabaho niya inside the body. Insulin secretagogues. So we have examples like sulfonylureas, meglitinides, and the diphenylalanin derivatives. Now, among our insulin secretagogues, the sulfonylureas are very common. Ito yung parating ginagamit. Again, the sulfonylureas. And from the name itself, they contain sulfur in their structure. And I think I have mentioned sa inyo na if a drug contains sulfur, the patient may be at risk of having like allergic reactions, especially in the skin, in which the most severe one is called the Stevens-Johnson syndrome. Okay, and aside from that, they should not be given to patients with G6PD deficiency, because they will have hemolytic anemia if they're going to consume foods or even drugs with sulfur. That's the problem with sulfonylureas. But then again, these are the most common insulin secretagogues we have in the market. Now, aside from our insulin secretagogues, we also have our biguanides. Actually, isa lang biguanide natin. It's the metformin. But later we'll talk about that. And then we have thiazolidine-diones, the alpha-glucosidase inhibitors. We also have incretin-based therapies and the amylin analogs, which are given subcutaneously, just like our insulin. But then again, they are different from insulin. They just have the same route of administration. Okay? So, wait lang. Okay, let's discuss them one by one. We have the first one, insulin secretagogue. So definitely these are drugs that will help our body release a lot of insulin from our beta cells. So this is not used for patients with type 1 diabetes mellitus. Remember, yung sa type 1, they are really insulin dependent from the outside source because their body cannot make their own insulin. So, itong insulin secretagogues natin are just given to type 2 DM. Okay? Kasi sa type 2 DM, their pancreas is still able to produce insulin. Let's just help the pancreas to release more of it. That's insulin secretagogues. And when you are going to use biguanides, its action naman in the body is to decrease hepatic glucose production. So what do I mean by that? Our own body class is capable of producing our own glucose for as a source of energy. Because remember, our liver Okay, hepatic ito ha. Our liver stores a lot of glycogen. That's our stored polysaccharide, right? So we can always get this glycogen and break it down to produce a lot of glucose. Now, that will be inhibited by our biguanides. And then, we also have the thiazolidinediones, which reduce insulin resistance. So basically, our oral hypoglycemic agents are only used for type 2 DM, especially our thiazolidinediones also. Because remember, type 2 DM, the patient is still capable of producing insulin. But one problem here is that there is insensitivity of the cells to insulin. They are resistant to insulin, so you cannot use this hormone to regulate the blood sugar level. Now, when you are going to use these drugs, thiazolidinediones, syempre, they will reduce the resistance so that you can have the action of insulin, and that can treat class the hyperglycemia that is experienced by the patient. Okay, now we have incretin-based therapies which are used to control postprandial excursions of our glucose. What do I mean by postprandial? Diba? After eating. Okay? After meal, there will be an increase in blood sugar level. So that's the work of the incretin-based therapies. How do these therapies class control these excursions of our blood sugar level after eating? It's through decreasing insulin resistance also, just like our thiazolidinediones. And at the same time, it can decrease glucagon secretion. Remember, glucagon is another hormone produced by our pancreas, and the action is the complete reverse or complete opposite of the insulin. Glucagon is used to break down our glycogen from the liver and break it down to glucose and take it back to the blood. So incretin-based therapies will inhibit that. Okay? And amylin analog also are used to prevent excursions of blood sugar level after eating. And at the same time, this has an action in the appetite. This may reduce the patient's appetite. Okay? And then you have here alpha glucosidase inhibitors, which is used to slow down our digestion sa carbohydrates, especially our starch, no? Hindi maa-absorb ang ating starch and disaccharides if we are going to take alpha glucosidase inhibitors. I'll talk about that later. Paano nito ini-inhibit yung absorption ng starch and disaccharide, and what will happen to you if hindi natin yan sila ma-absorb. Okay? But let's concentrate first to our insulin secretagogues. Okay? Para alam nyo na ito palang dinedispense ko sa community pharmacy is an insulin secretagogue. Okay? So the first one again is we have the sulfonylureas. Okay? So what's the mechanism of action? It will actually just help the pancreas, trigger the pancreas to release a lot of insulin. Okay? May action siya in the beta cells of the pancreas. Most of the time, it will be on the potassium channel. Kasi if we're going to close the potassium channel, di ba ang potassium is supposed to be inside the cell. So there is a potassium channel wherein potassium enters or exit the cell. We're going to close that. A lot of insulin will be released. So most of the time, our insulin secretagogues work in that area sa potassium na channel. But nevertheless, the result will be an increase in the insulin secretion. And at the same time, sulfonylureas may also reduce levels of glucagon in the body. Okay? Kasi in the case of diabetes mellitus, remember, we don't really need a lot of glucagon kasi glucagon is used to increase blood sugar level. Okay? So, we are going to divide our sulfonylureas to whether they are first generation or second gen already. We have two here under the first generation sulfonylureas. I think three pala. We have tolbutamide, which has a short half-life and is actually the safest sulfonylureas we can give to our elderly na diabetic patient. Okay, the safest among our sulfonylureas. I just don't know if this is still available in the market though. I haven't seen tolbutamide for a long time, but if you encounter this one in the pharmacy, it is a first generation sulfonylurea. Okay, given to patients with type 2 diabetes mellitus. However, since this has short half-life class, basically you will be giving this at least twice or thrice a day. Okay, that's for the tolbutamide. Now, however, since it will trigger the release of a lot of insulin in the body, then the patient may experience prolonged hypoglycemia. Okay? Please remember medyo mas delikado itong hypoglycemia kaysa kay hyperglycemia. Both are life-threatening, but if the patient kasi experiences hypoglycemia, especially if it's prolonged plus, the patient may be comatose. Okay? So yan yung iniiwasan natin. Now, aside from tolbutamide, chlorpropamide is another first-gen sulfonylureas given as maintenance drug. Every morning, we have 250 milligrams. Okay? So they have the same mechanism of action. However, this is more toxic compared to the tolbutamide. Tolbutamide will only just cause prolonged hypoglycemia. However, chlorpropamide, especially if you reach a dose of 500 milligrams, may target the liver and cause jaundice. Then aside from the liver, it may target also the kidneys, causing renal insufficiency, and hyperemic flush after alcohol ingestion in genetically predisposed patients. What do I mean by this? If the patient is in chlorpropamide treatment, kailangan hindi dapat siya magkaroon ng alcohol intake. Okay? Hindi pwedeng uminom siya ng alcohol kasi there will be a reaction in the body between alcohol and chlorpropamide. Okay, the patient may experience hyperemic flushing. Okay, and then pwede ding the patient will have delusional hyponatremia and other hematologic toxicity that's in the blood. So basically, chlorpropamide is not really considered a safe drug. Okay, but it belongs to the first generation sulfonylureas. And lastly, we have here tolazamide, which is comparable to chlorpropamide in terms of its potency. So the dose is almost similar. The dose required to elicit pharmacologic action is almost similar to chlorpropamide. However, it has a shorter duration of action. Okay, shorter DOA means duration of action. So this might be given mas maraming times a day compared to chlorpropamide. Need po ba ang RX? Yeah, you need RX for this kind of treatments. Actually, lahat ng mga na-discuss ko so far sa inyo, all of them are prescription drugs. If you're going to look at their label, you will really see the RX sign. Diba that's how you know that the substance or a drug is an OTC drug or a prescription drug. Look at the label. If it contains RX, automatically it's a prescription drug. So supposedly, if you're going to dispense these medications, anti-hypertensive, drugs for heart failure, drugs for diabetes, all of them are prescription drugs. So you should be looking for a prescription for this one. Okay? That's our problem here in the Philippines. What's our problem? Ang sales. Yeah, aspirin. Aspirin is a prescription drug, especially a higher dose of that. Bakit sila nag-dispense? It's our problem with our practice here in the Philippines. We are not really that strict when it comes to prescriptions. Diba? We are only strict with antibiotics. Dati, kahit antibiotics, they are not strict. Pag sinabing bibili ang patient ng amoxicillin, ibibigay na lang kaagad. Ngayon, they are stricter sa antibiotic because of our drive, our program for antimicrobial resistance. However, that is not yet true for the other prescription medicines. Kasi class ganito. Supposedly kasi, if a patient is diagnosed with example diabetes mellitus and then the doctor will prescribe drug, most of the time it will just start for 30 pieces. Example, metformin yung binigay. 30 pieces lang talaga yan. Kasi after maubos mo yung 30 pieces, so that will be good for a month, kailangan mo kasi talagang bumalik sa doktor to check whether naiayos ba yung blood sugar level mo or hindi. Kasi kung hindi, the drug might not be effective sa iyo or that underdose ka, kailangan taasan ng dose. Okay? Now, ano kasi ginagawa ngayon sa atin sa Philippines? Pag binigyan ka ng doktor ng 30 pieces, most of the people in the community assumes na, oh, maintenance drug niya na yun. And naging maintenance forever na siya. So, bibili na lang kahit naubos na yung 30 pieces. Okay? Now, kapag ganun kasi, after 30 pieces, bumalik siya sa doctor and there will be evaluation again. The next medication for that, if hindi talaga na-control ang kanyang condition, like sa sugar niya, another prescription na naman yan, and most of the time the prescription will be good for 3 months. Okay? And ayun, iinumin niya talaga yun, diretso-diretso for 3 months. And then pag na-end na yung 3 months na yun, na-fill mo na yung prescription, for example, 120, no, 90 lang, wala 90. Okay, 3 or 4 months kasi some of them will be giving 120 pieces. Kailangan mo kasi talagang bumalik sa doktor for evaluation. Kasi sige lang kag inom din ha og tambal, wala man di ka natamblan, no. Okay? Wala man di ay na normalize or like na-control ang blood sugar level. So, ayun. Ang mga pharmacy ngayon, nagdi-dispense pa rin ng mga prescription drugs without the prescription. And it has given plus a wrong conception. Ano tawag dyan? Misconception sa mga patients natin na pag maintenance drug, maintenance forever na yun, and they can just go back to the pharmacy every now and then and buy this medication. And yan din yung reason nga nung daghan kayong drugs that are prescribed by the neighbor. Di ba daghan og drug nga ang nag-prescribe ang silingan kanang nabang diabetic pud ka gainom ko og metformin, so mag-inom pud siya og metformin kay mao pud ang inom sa iyang silingan nya kay moadto ra man siya sa pharmacy, ma'am na may metformin and that's it. Okay, wala check sa condition. Ang uban din habsig na nakumatos na sa nakumatos na sa hypoglycemia, wala jud wala nakabalo kay walang check up, walang evaluation, wala sundog-sundog lang. That's our problem with dispensing medications which are supposedly prescription drugs. So take note ha, prescription drugs ito lahat. Okay? Now, mangugat-ngugat nag-discuss din pero they just call it like very idealistic kasi it's not the actual happening in the pharmacy. Yan ang ating problema. I hope we can correct that someday. Anyway, second generation agents, second generation sulfonylureas. Ito ha, we have here the glyburide, which is most commonly known in the pharmacy as glibenclamide. Okay. Kailangan mo glibenclamide, no? Kasi common naman yan siya in the community. And then we have the glipizide and the glimepiride. I hope the next time you have your duty, you can easily identify them, that they are second generation sulfonylureas. Okay? So definitely, since this is a sulfonylurea, it has the same mechanism of action with that of the first gen. Increase insulin release from the pancreas. Okay? But they have different pharmacokinetic profiles and they have different toxicities or adverse drug reactions. So just like for glyburide or glibenclamide, we have here the hypoglycemia, still the hypoglycemia, and then there will be flushing after alcohol ingestion. So please, it is a no-no to uh, administer alcohol, like drink alcohol concomitantly with your drug. Huwag mo talagang isabay. There will be flushing. Okay? What do you mean by flushing? There will be vasodilation and the patient will experience more mainit. Okay, mamumula yung patient mo nito. And contraindication, we don't give glyburide and glibenclamide if a patient has a problem with the kidney and the liver. Okay, contraindication. CI ha is contraindication. And then glipizide. So among our second generation sulfonylureas, this has the shortest half-life. Now, since it has a short half-life, you have to give this 30 minutes before meal. After 30 minutes, absorption happens. And if absorption happens, then there will be distribution. It will reach its target site and automatically it will elicit its pharmacologic action. But just like our glyburide or glibenclamide, we don't give this to patients with problems in the kidney and the liver. Okay? And we have here glimepiride, which can be given once a day. Okay? OD is once a day as monotherapy. So, pwedeng glimepiride lang talaga yung drug ng ating patient. Pero glimepiride may also be combined with insulin. So take note, class, insulin is not just a treatment for type 1 diabetes mellitus, but you can also give that to patients with type 2. Actually, nowadays, the doctors for mga endocrinologists natin or doctors natin for diabetes class are actually shifting to the use of insulin and getting away from the oral hypoglycemic agents, even if the patient is diagnosed with type 2 DM. Okay? Questions about our sulfonylureas. Our second generation sulfonylureas, most of them starts with G. Okay, glyburide, glibenclamide, glipizide, glimepiride. Okay, now we have meglitinide, but these drugs are not really that common, especially here in the Philippines, but still they are insulin secretagogues. And how do they do that? They modulate release of insulin by regulating potassium efflux. So ito yung sabi ko kanina na more insulin will be released if potassium stays inside the cell. Okay? Again, if potassium stays inside the cell, insulin will be released from the pancreas. Therefore, these drugs here, na kaning mga insulin secretagogues natin, most of them take their action in the modulation or in the inhibition of potassium efflux. They will close the potassium channel. Okay? So, pag na-close, potassium will be trapped inside, hindi na siya lalabas. And that will be the time that there will be exocytosis of insulin. So the first member under the meglitinide is the drug called repaglinide. Okay, which has a rapid onset of action and ginagamit siya, binibigay siya before meal 2 inhibit or prevent postprandial glucose increase or excursions. Okay? And what is the advantage of using repaglinide than our sulfonylureas? These don't have sulfur in its structure, so definitely you will not, the patient will not experience the allergic reactions na common to sulfonylureas. Okay, and then we have the third one under our insulin secretagogues. We have the diphenylalanine derivative, which has the same mechanism of action with that of the meglitinide. This will also trigger insulin release in the pancreas by inhibiting the potassium channel, or it will close the potassium channels. The potassium channels, by the way, are ATP sensitive. So this will just close or open if there is the presence of ATP. Inhibit niya yon. So what's our drug under the diphenylalanine derivative? We have here the nateglinide. Kanina it's repaglinide under the meglitinide. And then for the phenylalanine derivative, we have the nateglinide. Pero actually, they have the same way of administration with that of the repaglinide. They are given before meals kasi ang pinipigilan talaga nito is yung pagtaas ng blood sugar level after mong kumain. Okay? So this is safest for patients with reduced renal functions. Remember, most of our sulfonylureas should not be given if a patient has a problem sa kidneys niya. Okay? And this is most efficacious when given alone or in combination with non-secretagogues. So pwede siyang i-partner with metformin. Metformin class, which is the most common oral hypoglycemic agent, is not an insulin secretagogue. Hindi siya kasali dito. So it may be partnered with nateglinide, and we will have like a synergistic action with this one. Okay? And this is used for isolated cases of postprandial hyperglycemia. So ito talaga ang gamit niya. Yung after kumain, i-prevent natin yung pagtaas ng blood glucose level. Okay, so that's the end of the insulin secretagogues. Questions or clarifications? May gusto kayong itanong? Patulugan kayo, gusto magtindog, mag-stretch. MOA, second generation, they have the same mechanism of action with that of the first generation. Insulin release. Magti-trigger sila in the pancreas to release a lot of insulin. So like most of the time it will be on the closure of the potassium channel. Kasi pag na-close yung potassium stays inside the cell. Na-close yung channel, potassium stays inside the cell. And if potassium stays inside the cell, it will trigger the exocytosis of insulin, which is found inside the beta cells in the pancreas. Okay, they have the same mechanism of action. Itong mga insulin secretagogues natin. Okay, anything else? Baka meron pa. So pag wala na, let's talk about the biguanides. We only have one drug under this category, and that is the metformin. So again, metformin is not an insulin secretagogue. So how is metformin used for diabetes mellitus? What's the mechanism of action? Metformin class reduces hepatic glucose production. Paano? Nag-activate ito siya ng certain protein kinase, that's an enzyme that will trigger the breakdown of glycogen from our liver to produce glucose. So, ang target ng metformin talaga, 'di ba, yung glucose natin. Yung liver natin, nagpo-produce siya ng glucose. Doon galing sa mga na-store natin na glycogen. Yun yung pipigilan ngayon ng metformin. Okay? Aside from that, kasi may mga kinakain tayo like fructose. If we are into eating fruits, 'di ba? Our fruit sugar is called fructose. Fructose is metabolized in the liver And then if it is metabolized in the liver, it will be converted to glucose. So isa pa yan sa pinipigilan ng metformin. Aside sa yung own glucose talaga from the glycogen, yung mga other pa natin na kinakain na mako-convert in the liver to glucose, pipigilan yan siya ng metformin. Okay? That's the mechanism of action ng drug na ito. So that's through the activation of the enzyme AMP activated protein kinase. Combination drug of our insulin secretagogues, I'm not really familiar if we have combination drugs. Kasi most of the time I just see monotherapy like glibenclamide lang talaga siya. Pag glipizide lang din. Pag glimepiride lang din. I'm not really familiar if they have really made combination therapies. But let's see. Baka meron. Baka may combination ng sulfonylureas and metformin. Ay, char lang. Sulfonyl. Ureas. Don't have time anymore. I cannot finish this one. Wala, no. Diabeta is glyburide. Diabetes is good. I just don't know if meron ba. Glibenclamide plus metformin. I think meron. Glucovans. Okay. Na-happy ko. Can you check the brand name Glucovans? Glucovans is a combination of glibenclamide, which is an insulin secretagogue, tapos combination siya ng metformin. Hindi nga lang ako nakakita ng both. We don't usually combine drugs with the same mechanism of action class. How we call that duplication. Again, hindi tayo nagko-combine ng drug kung pareha sila ng mechanism of action. Most of the time, we do combination drugs kapag hindi sila magkapareho ng mechanism of action pero the same ang effect nila. Nakuha niyo? Like this one. Glibenclamide plus metformin. Both of them can lower the blood sugar level. But if we are going to look at their mechanism of action, they have different MOAs. So that's the time, yes, we can combine the two drugs. Okay? Pero hindi pwedeng magkapareho na sulfonylureas plus sulfonylureas. Ang tawag natin dyan again, duplication. And pag na-duplicate na kasi yan, wala lang din siyang naitulong. Kasi parehas lang sila ng mechanism of action. That's the same thing, metformin. Pag nilagyan siya ng HCl class, meaning the metformin is made as a salt. Okay? Metformin is a basic drug and it is combined with hydrochloric acid. Remember, acid plus base is equal to salt. So, kaya base na metformin, hydrochloric acid, syempre acid, salt siya. Bakit most of our drugs are made as a salt? Because remember in your study sa biopharmaceutics, sa pharmacokinetics, we have the so-called liberation. We need to liberate. We need to release the active ingredient para magkaroon siya ng effect in the body. And how are we going to liberate the drug? Number one, through disintegration, especially for orally given drugs like tablets and capsule. Kailangan niya muna mag-disintegrate. Kailangan niyang mag-break down into small or fine particles. And then after disintegration, we have dissolution. Meaning, the drug should be dissolved. Most of the time, it will be in aqueous solution. Kailangan in water before siya ma-absorb. Okay? Now, the form of the drug that is easily dissolved is the salt form. So, yan yung reason class bakit nakasalt yung mga drugs natin sa market. And yun yung nakikita nyo na minsan mga HCl sila, ganon. Okay, yan yung explanation yan. Pero that's still metformin. Metformin HCl or metformin is the same thing. Ginawa lang talagang salt yung isa para madali siyang ma-dissolve. Naintindihan yan? Or do you have other questions? Hindi ba siya matapos? Okay. It's already 11:53. Wala. Now, what is good for metformin is the patient may experience less fasting hyperglycemia. Ang problema kasi natin sa mga patients natin with diabetes class, pag hindi sila kumain, meaning nag-skip sila ng meal, okay? Pag nag-skip ng meal yung mga diabetic patients, lalong tataas ang kanilang blood sugar level. Okay, again, pag mag-skip ng meal ang diabetic patients, lalong tataas ang kanilang blood sugar level. Bakit? Kasi 'di ba, meron tayong glycogen in our liver. Okay? Now, the body is in need of energy. So, the liver will react. It will break down its glycogen, stored glycogen, make it as a glucose, and take it back to the blood. So, that's the case. Tataas pa yung blood sugar level nila. So, yun yung pipigilan ngayon ng metformin. Since nag-reduce siya ng hepatic glucose production, even if the patient is like fasting, hindi siya masyadong makaka-experience ng hyperglycemia. So if you know someone with diabetes, you really have to tell them that they don't need to skip meals. Hindi sila pwedeng mag-skip ng pagkain. Thank you po. Okay? Nasabtan to. And then it can lower postprandial hyperglycemia also. So after taking metformin, even if kumain sila, di ba? Another problem with diabetes patient is after nilang kumain, tataas din yung sugar. Pag hindi sila kumain, tataas yung sugar nila. Pag kumain sila, tataas din yung sugar nila. So, yun yung pinipigilan ng metformin dyan. Both of that. So, we will have euglycemic na effect. When you say euglycemic agent si metformin, it means it can maintain the blood glucose level at normal level. And another advantage of metformin is it does not cause hypoglycemia. Magno-normalize lang talaga ang sugar, pero unlike other drugs, 'di ba ang drug kan yung sulfonylureas, nagko-cause sila ng hypoglycemia. That is not true for metformin. Unless na lang kung i-combine mo si metformin with other agents. Yun. Yung agent na yun ang magkakos ng hypoglycemia. But metformin itself will not. And that is the reason why metformin is like commonly used, the most commonly used oral hypoglycemic agent nowadays. Okay? Paano po ma-excrete ang glucose if hindi siya ilalabas ng liver? It will just be stored in the liver as glycogen. Kapag hindi mo nagamit yung glucose mo, ganito. Pag kumain ka kasi class, yung glucose mo, kung okay yung action ng insulin mo, ilalagay yan siya, ipapasok yan siya inside the cell through the help of the hormone insulin. Kasi si glycolysis takes place in the cytoplasm. Okay? So that will be inside the cell. Kasi pag sinabing glycolysis, that's breaking down of glucose para ma-convert siya into ATP. So ginagamit lang talaga natin ang glucose class. Convert lang natin siya sa ATP para may energy tayo. Na ang problema, kapag hindi mo nagamit yung glucose mo, or kung nagamit mo yung iba excessive na talaga, kay daghan jud kayo imong gikaon. Kaya di ba ang atong dapat supposedly kaunon? And the size of our fist, ingana pud kadaghan nga rice ang ato ang kaunon. So kung daghan jud kay duha ka fist ang gikan tos wala tay gihimo. The excessive sugar or excessive glucose will be stored in the liver as glycogen. And it's not just in the liver, it will also be stored as glycogen in the skeletal muscle. Okay? And it will just stay there unless na lang kung dumating yung time na kakailanganin natin siya kasi magbe-breakdown yan siya. I-breakdown niya siya as glucose para ibabalik siya sa blood para pag nasa blood na siya, pwede na siyang ma-distribute in the cell and mag-undergo ng glycolysis. However, yung problem talaga natin kung napuno na si liver, napuno na si skeletal muscle, tapos mas marami pa talaga ang kinain natin, like duha na tulo ka feast, imuhang gikaw, nagmang inasal, kadaghan kay imong gikaw nga rice. Tapos nagsudan pa kag bihon aside sa normally mga sudan, diba? Those are carbohydrates lahat. Pag sobra-sobra na talaga, class, sobrang glucose will be converted into fats. Okay. And if it is converted into fats inside the body, that's the time it will be stored in the adipose tissues. So asa makita ng adipose tissues, syempre daghan sa tiyan. So muna ko imong tiyan, daghan sa imong nawong, muna mo bilog imong nawong. And then sa imong mga diri. Okay? So ginagamit natin talaga yung glucose natin in the body. Mag-store yan siya sa liver, dyan lang yan siya. Mag-store yan siya sa fats mo, dyan lang yan siya. I mean, ma-store siya sa adipose tissues as fats. O dili ni mo siya gamiton, diha lang yun na siya. Dako lang yun mong naong, huwag imong tiyan, ana lang. Okay, did I answer your question? Or do you have other questions aside from that? Wala na. I'll just finish metformin. Metformin is our first line therapy for type 2 diabetes. Ito talaga yung first line natin. Kaya ito yung pinaka ginagamit. Okay? So this one is insulin sparing agent. Hindi niya talaga pinapakialaman yung insulin class. So that is the reason why hindi siya nagpapa-increase ng weight. Yung problem kasi natin with other agents, pag na-control na ang sugar, especially if they are insulin secretagogue. Ang insulin kasi, gagamitin natin yung glucose. Pero ang problem with insulin, magsustor siya ng maraming fats. Okay, nagamit yung glucose, pero yung fats mo sa body will stay in the adipose tissues. So, ang isang adverse reaction ng ating other hypoglycemic agents involving insulin and even insulin itself is pag na-control na ang blood sugar, talagang tataba yung patient. And yan yung advantage ni metformin. Hindi siya nag-cause ng weight gain and hindi din siya nag-cause ng hypoglycemia. Yeah, both type 1 and type 2 diabetes mellitus applicable yung never skip a meal. Talagang kakain sila pero in moderation, ha. So what's the problem with taking metformin? Metformin is known to cause gastrointestinal distress, hapdo sa tiyan, or it can even cause diarrhea. And ang life-threatening na talagang adverse effect of metformin is the lactic acidosis. Okay? Because 'di ba its target is the liver, yung lactic acid natin sa body na metabolism yung matatamaan, leading to an increase in the lactic acid inside. Kaya nga siya may GI distress kasi lactic acid is a well-known GI irritant. And at the same time, sa blood mismo, sa body mismo, lactic acid will accumulate and leading to acidosis. Okay, na-mention natin ang acidosis kanina. Bababa yung pH, less than 7.35. And remember, if there is acidosis, life-threatening siya. The organs, the tissues, our other biomolecules in the body will not function well or efficiently. Okay? So ito yun, pagtatanungin kayo the life-threatening na ni 1202 na ay lactic acidosis, yun siya. And lastly, ito yung mga contraindications. Do not give metformin to these patients. Okay, renal disease, alcoholism, hepatic disease, and conditions predisposing to tissue anoxia. Just like yung may mga problems sa lungs. Okay, so we'll end there.